Dr. Patel. Hi, come on up. Thank you very much for coming to our meeting and speaking.
Thank you for inviting me, Dr. Thorpe, Dr. Ramaya.
Thrombectomy, good.
I'm Nachiket Patel. I'm an interventional cardiologist here in Mesa. I appreciate the.
You can leave. No, joking.
Thank you for the. Where's the clicker?
Oh, sure.
Oh, thank you. All right, perfect. So I'm happy to talk to you about the thrombectomy for acute PE, devices and trials. So PE is the third largest cause of cardiovascular-related death worldwide. Mortality depends on the severity of the event and patient comorbidities. Basically, three categories that the severity of the PE is divided into: high risk or massive PE, where there's hemodynamic instability, shock; intermediate risk or submassive PE, where there's evidence of right heart strain, either most commonly diagnosed on CT scan, and we can see on echocardiogram, elevation in their troponin levels and their pro-BNP, and then low-risk patients that have stable hemodynamics and normal RV function. So for the high-risk type, they're going to get unless they have a contraindication, they're going to get systemic thrombolytics. For the low risk, they're going to be started on oral anticoagulation and then discharged. For the intermediate risk is, the optimal management is kind of totally, not completely known. And so, however, that intermediate risk PE patients, like they have a high 30-day morbidity and mortality, whether it's like readmission. And so standard anticoagulation might not be sufficient. So they've looked at two trials looking at lytic therapy for intermediate risk PEs. And while there was benefit in RV function, there was no benefit in chronic RV dysfunction for intermediate risk. There was no benefit in mortality. And then the trade-off was that there was increased bleeding, including hemorrhagic stroke. So then, in order to minimize the amount of lytics or the dose of lytics that are given to these patients, they looked at catheter-directed therapies. And the whole idea there is to reduce the clot burden and therefore RV strain. And then hopefully by reducing the systemic fibrinolytic dose, you're reducing their bleeding risk. The most common one used right now, I think, is echoes. It's ultrasound facilitated, or you could just people have used like standard infusion catheters also. And then I'll quickly talk about some of the data for the mechanical thrombectomy device, specifically ones by Inari, Penumbra, and then AngioDynamics. So I don't do echoes that much, but here's an image of one that I did a couple of years ago. So this a catheter, I think it was like an 8 French catheter, or 7.6 French specifically, introduced into the bilateral pulmonary arteries. So this you insert an ultrasound core, which then is supposed to disrupt the fibrin fibers and then enhance the drug penetration into the thrombus. They've studied this in the Ultima trial, where they compared echoes versus anticoagulation in submassive PE with RV dysfunction, and it did show a significantly greater reduction in RV-LV ratio in the echoes group. No major bleeding events. And then they also studied it in the Seattle 2 trial, which was a single-arm study with 150 patients looking at echoes plus anticoagulation. Similar kind of thing. Low major risk of bleeding, but improvement in their RV function. So it just kind of reinforces it as a treatment option in intermediate risk PE. Optilase then took it a step further and randomized patients into different doses and different infusion times. And all treatment arms showed a significant reduction in the RV-LV ratio. Including the shorter, lower dose protocols. They were effective with lower bleeding. 2 patients of note did have intracranial hemorrhage. 1 was attributed to the lytic itself. And so again, supports the use of lytic catheters and including lower dose regimens, infusion regimens. So And putting a lytic catheter in still has a risk of bleeding, including intracranial hemorrhage and an ICU stay monitoring. And so one of the reasons to look at mechanical thrombectomy would be rapid removal of the clot. You wouldn't need thrombolytics, and therefore hopefully get immediate reduction in the RV strain and pulmonary pressures, and then right away maybe have an improvement in their symptoms right away. Again, the idea being you don't have to be in the ICU getting lytic catheters, getting your fibrinogen levels monitored, and so after the procedure, maybe an overnight stay in a telemetry floor and then discharge the next day. Inari is one of them that's probably, they have the most amount of data for. It's the one that I most commonly use. It comes in 16, 20, and 24 French systems. Basically, you get femoral venous access. I pre-close the venotomy with 2 per-close devices. You take a pigtail catheter or something similar, advance it to the pulmonary artery, and then once you get the catheter up there, it's basically like a 50 cc negative suction syringe that removes the thrombus once you position it into the area that you want to remove the thrombus from. And the images are pretty dramatic. So here's one I did a couple months ago. Probably 40 minutes. It's kind of nice. They come in on 8 liters, and by the time they're getting off the table, they're satting 94, 95% on room air. So it's gratifying to do and you see the immediate result. So they studied this in a few trials. So many of these trials are going to be prospective, multi-center, single arm, where they're looking at the same thing. How safe is it, and does it reduce right ventricular strain? So this FLAIR trial looked at 106 patients with intermediate risk PE. They underwent mechanical thrombectomy using the FlowTriever device. They looked at RV-LV diameter ratio from baseline to 48 hours. There was a significant reduction in that ratio, low rate of major complications, and then importantly, the procedures performed without need for thrombolytic medications. Next is the FLUSH registry. I think this included, it's an ongoing registry. I think this one that was published in 2023 included about 800 patients. So real world patients with acute PE, predominantly intermediate risk, but did include some high risk patients too. Again, marked improvement in RV function, low risk of major bleeding and device-related complications. So it just reinforces the efficacy and feasibility of doing mechanical thrombectomy for intermediate risk PEs. And then I thought this was interesting. So this is a prospective multi-center observational study, but they had 2 parallel registries, and they included high-risk PE patients. So they defined that with hypotension and need for vasopressor support. So one patient, so this is, I'm sorry. So population, it was a FlowTriever arm and then contemporary therapy. Of the contemporary therapy patients, 69% received systemic thrombolytics. So interestingly, it met the primary endpoint of all-cause mortality, clinical deterioration, major bleeding. Sorry about that. So, and then it was primary, and that primary endpoint was primarily driven by all-cause mortality, 1.9% compared to 30% in the just the contemporary therapy arm. I had 18 minutes, I thought, so this is a little longer, but I'll kind of speed it up a little bit.
Oh, there were 8 minutes.
8 minutes? Okay.
18.
Is that right? Okay.
Yeah.
Well, no, so I'm just going to speed it up a little bit. So the Penumbra device, it's using a catheter with what they call intelligent aspiration. It's basically a computer-assisted vacuum thrombectomy. They have 3 different sizes. Most they have 16, 8, 12, and 16. You can see a good result from that there. And then same kind of thing here, extract PE, where they use the Lightning 8, which is the smallest one. Now you get more thrombus removal, and it's a lot faster when you're using the larger devices. So the Strike PE trial, the interim analysis of that, they use the Lightning 12, and again, same thing, improvement in the right heart strain, and then the dyspnea score at 60 to 90 days. And then lastly, the AngioVac system, recently approved. I haven't used it. I don't know if anybody here has used it. it's a similar type of, in my mind, it's a little bit similar to the Inari device where you're using like a suction, but instead of a suction from a syringe, you have this handle mechanism where when you squeeze it, it's giving you suction. You can set it to 10 cc's or 30 cc's, and you can either lock it and then move the catheter around or suction with your hand real time. So future trials, Perilous 2, doesn't make sense to me. Perilous 1 showed that the Inari was beneficial compared to catheter-directed thrombolysis. It seems like it was done in reverse order, but the Perilous 2, the Inari, it's going to compare the Inari versus anticoagulation, Storm PE, looking at the Lightning 16, which is the largest catheter with Inari or with penumbra versus anticoagulation, and then the PE tract, looking at any available mechanical thrombectomy catheter versus catheter-directed thrombolysis. Importantly for that trial, there's a 6-year planned follow-up. So and that's kind of what we need. We need long-term data on it and head-to-head randomized controlled trials. So conclusions, both catheter-based lysis or mechanical aspiration offers rapid improvement in intermediate risk PE. Choice depends on patient characteristics, bleeding risk, and then your local expertise and availability. So thank you for your attention.